And I was specifically, I had this question on my mind, so is it for all cases or just in complex anatomies? And then if you just look at your just regular, hold on. If you look at your regular CT, then, I mean, if you have clear dimensions, if you have a wide sinus, if you have a good coronary distance and no severe calcification, I don't think most of us and most of the centers in the world would need a patient-specific computer simulation. You just, put the valve in that you're experienced with, and you from your professional experience probably will know that this valve is going to work very well in this anatomy, and that you have all the check boxes marked that there's no danger in coronaries and so on. But we've already talked a little bit about bicuspids. I mean, in some of the regions of the world, it's more common. We heard that before as well. And for us, I mean, looking at a bicuspid on a patient-specific computer simulation is sometimes very helpful. I mean, for example, just looking at the plain CT images, I was actually thinking that that was a VAV type 0, but then if you look at the simulation here, you can see that there's an LR RAFI and a heavy calcification of the other sinus or of the other cusp. And so if you simulate that valve in the computer and then put an evolute prosthesis in, then you can actually see that the deformation will be very, very intense. And then you can also look at the contact pressure that the valve is going to have in that area between right and non-coronary septum, so that you can actually see maybe we have a high pacemaker rate, or maybe we should implant higher. And then you can try to find out what valve, what size, and maybe also what height you want to implant, and that helps you to get better results. So in heavily calcified valves and in bicuspid valves, I see an advantage of that technique. Also, you might have some strange cases where you think, hey, is this actually feasible, what I'm trying to do? So if you have cases where, for example, you had an AV valve put in before interventional percutaneously, and then for us, in this case, it was the question, hey, is it actually possible to implant a TAVI prosthesis there without aligning with that mitral valve and maybe damaging the result we had there? And then you can play around with it, and you can look for implant height, and then you see, okay, if we end up really high, then we might actually have a chance not interfering one valve with the other, and then the result of that procedure was actually very good. And sometimes if you have you ask yourself the question, hey, what about patient safety? Should I really go forward with this procedure, or maybe get the heart surgeon involved? But we had this case, for example, with an interventricular membranous septal aneurysm, and I was actually looking at the contact pressure that you see right there down in the pictures below. I was worried that we have so much contact pressure in that area where that aneurysm is, that I was afraid that it might be ruptured or might rupture. And so we decided in the end to put an Evolute Pro 29 millimeters in there, but with a very high implant height, so that we actually could avoid that contact pressure that you see in the right lower corner. So to answer the question, do I think it's something that we need for all cases? No, I don't think it's something we need for standard cases, but for complex anatomies, I think the simulation can provide you with the instrumental information that you need regarding procedure outcome. And I think that's becoming more and more important the further we advance this technology. And also sometimes, is this feasible? And what is my patient safe?